friends, all those who are in India, and good evening to all those my friends in United States of America. And welcome to this 68th, no, sorry, this is 78th edition of our series of webinars being organized by the Andhra Medical College, Visakhapatnam on COVID-19. So I'm very glad that this has been happening with the help of so many luminaries, both in India as well as from America. To name a few, Dr. Sridhar Chilumuri, Dr. Rammohan Kairam, Dr. Kalpalata Guntupalli, and the host of speakers from the United States have greatly helped this event to go forward. And as you are all aware, that the cases are coming down even here in India, particularly in Visakhapatnam, where we are having Andhra Medical College. And as the situation is improving and positivity rate is between 2 to 3% over here. So earlier we have concentrated during the second wave on the protocols and important aspects in this management of the patients particularly. And we had a daily webinars for over a month. And Dr. Rammohan took a very keen interest in that. And today he is away at Salt Lake City with his family. He may not be able to join continuously. And he has asked me to convey his best wishes to Dr. Prateek Kulkarni, who has always been ready to share his expertise with us. Dr. Prateek Kulkarni has become very popular for his forceful presentation, as well as the way he drives the point home without any ambiguity. And as you're all aware that as time went by, we have been concentrating more on how to prevent third wave, how to take care of the variants, and what are the knowledge is being shared on variants, how do they happen, and what needs to be done. And we have been concentrating more on the vaccines, their availability, the strategies that need to be followed in vaccinating more number of people, as well as the vaccine escape that we have been observing these days. And the post-COVID sequelae, which have become very, very important. As we have reasonably good experience over the last 1.5 years, now we are seeing patients with different problems after suffering from COVID. So we thought we should have a series of lectures and discussions on post-COVID sequelae as well. So today we are going to talk on the variants, and the infectious disease specialist, Dr. Kulkarni, is again with us. And he'll be talking to us on the variants and the latest treatment protocols as well. And I request Dr. Kalpalata Guntupalli, the teacher for many of the intensivists in America, to moderate this particular session and take it forward. Over to you, Madam, Dr. Kalpalata Guntupalli.
Thank you so much. And it's wonderful that this is the 78th presentation. I don't know of any other medical center in India that has done so consistently. I think it's a great partnership between Dr. Kairam and Dr. Sudhakar. So I think everybody in the audience should appreciate the tenacity of these two doctors and alumni. I just wanted to properly introduce, I know many of you have already met Dr. Prateek Kulkarni. But Dr. Kulkarni is currently an assistant professor in the Department of Medicine section of Infectious Diseases and is also the associate program director for Infectious Diseases Fellowship at Baylor College of Medicine. He's also assistant chief of medicine at Michael E. DeBakey Veterans Affairs Medical Center, which is one of the 4 major affiliate hospitals of Baylor College of Medicine. Dr. Kulkarni did his undergraduation from Rice University, then medical school at Baylor College of Medicine. And he continued to finish his residency and was also a chief resident at Baylor College of Medicine. Subsequently, he did his infectious disease fellowship also at Baylor, but he spent 2 years with the CDC as a epidemiologic intelligence officer, which is a very interesting and coveted position with the Center for Disease Control. And he came back and joined as faculty at Baylor College of Medicine. He has received every teaching award there is from his medical school days all through residency and as a faculty. He's a very, very dear member of the faculty and very dear to the residents and students. So I'm very proud to present Dr. Prateek Kulkarni to talk about various aspects that are very relevant at this time, such as Delta variant and what vaccines cover and don't. Prateek.
Thank you so much, Dr. Gundapalli, and thank you, Dr. Sudhakar, for having me as well, and also Dr. Ram Kairam for the initial invitation many months ago to speak to all of you. I'm very grateful for the opportunity, and I hope that it can help some of my colleagues back in India. I'm originally, obviously, from India as well. I'm from Pune, actually. And so I hope that this is some way I can give something back to my home country. So I hope you find this presentation helpful, and thank you again for the kind invitation. Let me share my screen. Give me 1 minute. Okay. So let's go ahead and get started. And again, good evening for us. Good morning for all of you in India. I realize it's 6:30 in the morning there. So thank you all again for waking up early just to see this presentation. I'm very grateful. The subject of this presentation is the following: COVID-19 review of variants, vaccines, and then a few topics on infection prevention and control. And I know we've done a full segment on treatment of COVID-19, so I'm not going to go over everything again, but I thought maybe I could give a brief update of where we stand and what's changed in terms of treatment with COVID-19. Most of it is similar, but there are a few things that have changed. This is the outline for this presentation. I will review the major circulating SARS-CoV-2 variants, and specifically which vaccines are covering which variants, which I think is a very important topic right now, because even in America, there is a lot of concern that we are having breakthrough infections even after vaccination. And so I want to go over some of the data related to that. I will answer a few commonly asked questions about vaccines. Many of these are questions that I receive from non-medical people, meaning people outside of the medical community. But I think they're very helpful, very fundamental, but perhaps they will be helpful to everybody. Then I will review briefly isolation and quarantine strategies for COVID-19. Now, I realize the cases are coming down significantly, as Dr. Sudhakar mentioned. In India, they're coming down, which is great news. But I thought it could be helpful just to review some of the isolation and quarantine strategies as we enter, hopefully, less cases overall. And then finally, as I mentioned, I will provide a brief update on pharmacological treatment of COVID. I won't go in huge amount of detail, but I will review a few of the major highlights that have come up recently. And let me just say right now, I will share all of these PowerPoint slides with Dr. Gundapalli and Dr. Sudhakar and Dr. Kairam. I will be happy to send these slides, and please feel free to utilize them and distribute them as widely as you'd like. They are publicly available. I hope they are useful to you, and feel free to use them, send them to anybody you'd like to send them to as well. First, I just wanted to go over briefly the concept of how we classify SARS-CoV-2 variants. This is a screenshot from the website of the United States CDC, Centers for Disease Control and Prevention, and I put the reference website at the bottom there. And this was updated very recently, only 3, 4, 5 days ago. So it's very up to date. So if you want to know what is going on with the variants around the world, I would refer you to this website. It's very helpful. A few months ago, the US government put together a group to develop a system for classifying SARS-CoV-2 variants, because at that time, many variants were emerging, and we needed some rational way to classify variants. So there are 3 main classes of variants of SARS-CoV-2. One of them is, it's called variants of interest. Second one is called variants of concern. And third one is called variants of high consequence. And as you can see from the names, as you go down the list, they become more and more serious. So a variant of interest is defined as a variant with specific genetic markers, meaning specific mutations that have been associated with changes to the spike protein or other aspects of the virus, which can perhaps reduce neutralization by antibodies that have been generated against previous infection or vaccination. So the major variants of interest right now that CDC is tracking are the following. A few of them are from United States, in California and New York. There's one from United Kingdom, a couple from India, which are related to the Delta variant. They're slightly different, but related to Delta variant. And then another one related to a variant from Brazil. But these are all variants of interest. They have not yet risen to the category of variant of concern. These are potential theoretical problems, but have yet not been a major problem around the world. Variants of concern are really the major problem right now around the United States and around the world, actually, which all of you obviously know with the Delta variant in India. So a variant of concern is one category higher than a variant of interest. And a variant of concern is a variant for which there is evidence of increased transmissibility, more severe disease, significant reduction in neutralization by antibodies, or reduced effectiveness of treatment or vaccines. So the major variants of concern right now circulating around the world, in India and around the United States, are the following. B.1.1.7, which was originally detected in the United Kingdom in September, October, and really went up in November and December. There's a strain from South Africa, which has some unique characteristics. It is not as transmissible as Delta variant. I'll show you some slides about that going on, but anyway, it's also very serious. The main one, obviously, which all of you are familiar with in India, is the Delta variant, B.1.617.2, which has been very serious in India and is now becoming extremely serious in the United States, especially amongst people who are unvaccinated. And then finally, the P.1 strain, which was originally detected in Japan and Brazil as well. So these are the major variants of concern currently. And then finally, there's a category which is one level higher, called variants of high consequence. And a variant of high consequence is a variant that has clear evidence that prevention measures or medical countermeasures have significantly reduced effectiveness. So for example, there is demonstrated failure of diagnostics, meaning a PCR test doesn't work anymore to detect this variant because the genetic material is so different. There are so many mutations that it doesn't detect it anymore. Or there's significant reduction in vaccine effectiveness, huge number of vaccine breakthrough cases, or significantly reduced susceptibility to multiple therapies that we give for COVID-19. So this is the worst category, a variant of high consequence, because it has the potential to not be treated well. It also has the potential not to be diagnosed accurately. So it's the most dangerous category. Thankfully, currently, as of July 2021, right now in the world, there are no circulating SARS-CoV-2 variants of high consequence. All of the current variants are either variants of interest or variants of concern, which are serious, but they are not as dangerous as this category. Many of you probably know that towards the end of May 2021, beginning of June 2021, the World Health Organization announced a simple, easy to understand system for classifying SARS-CoV-2 variants of interest and concern. This made the nomenclature much easier to understand because previously people were saying UK variant or India variant or some other Brazil variant, something like that. Or they were using the number scheme, which was very difficult to understand, very difficult to communicate. Most people in the public don't necessarily know B.1, 0.61, all these things. So they made a very good system for naming these variants. So here are the main variants which were named by the World Health Organization at the beginning of June 2021. and they are the following: alpha, beta, gamma, delta, which I'm sure by now everybody is familiar with mostly. The alpha variant is the one that was initially discovered in the United Kingdom, UK. Beta is the variant that was discovered in South Africa, B.1.351. Gamma is the Brazil or Japanese variant. And then Delta, which everyone is familiar with, is the variant that was initially discovered in India, and now really currently in the United States is probably the dominant strain circulating in the US right now. Just for your awareness, there have been enough variants of interest that have developed that obviously they're following the Greek alphabet. They've gone all the way to lambda. So that means, you know, they've gone through alpha, beta, gamma, delta, epsilon, zeta, eta, theta, iota, kappa, lambda. So they've almost gone through maybe 10 or 12 variants that are significant. And so these other ones, we don't hear about them much, but these are currently variants of interest. And as I say, we've gone all the way to lambda. But still right now, the predominant circulating strain is delta. I'm not going to go over all this in detail, also in the interest of time, but I just want to bring to your attention what makes these variants more serious or more dangerous than other variants. Because as we all know, viruses, when they replicate, are constantly producing mutations. The question is, which mutations are serious and which mutations are not serious? And the majority of mutations are actually not serious, but it's just some fraction of mutations, small number, which can have the potential to become serious. So I just want to bring to your attention a few key mutations. It's probably not that important to know these, but just for your interest. There's one mutation, L452R, which is, of course, this is referring to amino acids. This is the old amino acid in the 452nd position. It's replaced by arginine, for example. The first one is what the old amino acid was. The second letter is what the new amino acid is. I'm sure everybody knows that. But this particular mutation is present in many variants, including delta. And it can make the virus more transmissible. And that's not necessarily only this mutation, but it's one reason why delta is more transmissible than some of the other variants. This is also an important mutation, E484K. It's present in alpha, beta, gamma strains, and it can sometimes cause some degree of immune evasion, meaning the antibodies that are generated can sometimes be not as effective against this particular, or strains which have this particular mutation. So those are a couple of mutations I wanted to bring to your attention. Again, clinically, they're not that relevant, but from a molecular biology standpoint, they can be important. So I'm just briefly now going to go over those four major variants of concern: alpha, beta, gamma, delta. So alpha is B.1.7. It was originally discovered in the United Kingdom. And what makes alpha significant is that it has approximately 50% increased transmission, and it has potentially increased severity. But our monoclonal antibody treatments are still very effective against alpha. And vaccination is generally quite effective against alpha. So minimal impact on neutralization by convalescent and post-vaccination sera. So alpha is a little bit more transmissible, but our treatments and our vaccines work very effectively against alpha. Beta was the strain originally discovered in South Africa. It's also more transmissible than the original strain. And importantly, it has significantly reduced susceptibility to some of our monoclonal antibody therapy, including the combination of bamlanivimab and etesevimab, which is the product made by the company Eli Lilly. I just wanted to mention that, and I'll talk about it a little bit later on in the presentation, but Eli Lilly, the United States government actually told Eli Lilly to stop distributing bamlanivimab and etesevimab because of immune evasion by beta and gamma variants. So actually in the United States, you cannot get bamlanivimab and etesevimab anymore. Anyway, I'll talk about that a little bit later. Luckily, though, this is not the predominant strain around the world or in the United States right now. It was mostly predominant in South Africa. Gamma has the potential to be serious. It was originally discovered in Japan and Brazil. It also has significantly reduced susceptibility to combination monoclonal antibody therapy. And it has some reduced neutralization by convalescent and post-vaccination sera. Luckily, though, also it has also not taken off in the United States. It is prevalent in some parts of the world, such as Brazil, for example, but it's not the dominant strain. Probably right now, the dominant strain around in the United States and around the world, and what was in India, was the Delta strain, which I know everyone is familiar with. And its attributes are that it's extremely transmissible. It is substantially more transmissible than the wild type, and substantially more transmissible than even the other variants. It has some potential reduction in neutralization by some of the monoclonal antibodies and some potential decrease in neutralization by post-vaccination sera. We're still learning about Delta. We don't know as much about it as we do about the other variants. So we have to be a little bit careful how we think about Delta. I think we still, I don't think we have the complete knowledge or understanding of Delta yet, but almost certainly it's more transmissible by a significant percentage. And it probably has some degree of immune evasion, but it's probably not as bad as we think it is. The number of breakthrough infections are probably higher, but perhaps not dramatically so. And I'll show you some data in the next few slides. So I want to summarize what we know about the current major variants of concern. And I want to give credit for this graphic to a colleague from Emory University School of Medicine, which is in Atlanta in the United States, Dr. B.K. Titanji. I borrowed this chart from her, so I just wanted to acknowledge her contribution to this. So as it shows, it's alpha, beta, gamma, delta. And on the left-hand side is disease severity, mortality, immune evasion, transmissibility, and the country where it was first identified. And if you look, for example, the alpha variant makes people more sick and is more deadly, but really doesn't have any effect on immune evasion. So our vaccines cover it pretty well. If you look at Delta, we're still not 100% sure about disease severity and mortality. Perhaps that's going to be increased as well. There is some degree of immune evasion, but not as bad as with Beta variant. But the transmissibility of Delta variant is very bad. So the problem we're having in the United States right now, especially amongst unvaccinated individuals, is that Delta is circulating very widely, especially amongst people who are unvaccinated. And for the first time in several months, cases in every area of the United States are going up as well, almost surely due to Delta variant because of this increased transmissibility. This is a little bit complicated chart, but I want to spend a little bit of time on it because I think it's very helpful and a very well done chart. So what it shows on the bottom is all the different types of vaccines: Pfizer, Moderna, AstraZeneca, Johnson & Johnson, Novavax, Covishield, which is available in India. Of course, that's the generic version of AstraZeneca. So, they're the same pretty much. Covaxin, which was developed in India, and then Sinovac. And what it shows is the coverage of each vaccine against each variant for all the different vaccine types and the percentage efficacy against preventing any type of symptomatic COVID, mild, moderate, or severe. So for example, if you take Pfizer, which was really the first vaccine developed here in the United States, as we all know from the original study published in November of 2020, Pfizer was 95% effective against preventing symptomatic COVID in the wild type. If you look at the variants for Pfizer, Alpha is still 94% effective. If you look at Beta, 75% effective. Even for Delta variant, it's 85 to 90% effective, which is still very good, actually. So Delta is very transmissible, but it's still relatively well covered with the mRNA vaccines. Moderna is a little bit lower at 70%. I want to draw your attention now to AstraZeneca and Covaxin, because these are the two that are predominantly available in India. So let me show you the next slide. So not necessarily AstraZeneca, but Covishield. Covishield is basically a generic version of AstraZeneca. So I'm just using that as the reference. So if you look, AstraZeneca, and again, this is against any type of symptomatic COVID, not necessarily severe COVID, any type of symptomatic COVID, mild, moderate, severe, anything. If you look at the wild type, AstraZeneca was about 75% efficacious at preventing COVID, symptomatic COVID. For alpha variant, it was about 70%. Now, for beta variant, the one from South Africa, it was really actually not very good. It was only 10% efficacious, but this was predominantly mild COVID-19, not necessarily severe COVID-19. For severe COVID-19, Covishield was still pretty good against beta variant. So this 10% looks very bad, but this was predominantly mild disease. Against Delta variant, it was still about 60 to 70% effective at any type of COVID, and probably higher for severe COVID. So bottom line is the following. Covishield probably has some decreased effectiveness against the Delta variant. However, it's still not terribly bad, and it could still be quite, reasonably effective at preventing people from ending up in the hospital or dying from COVID. Certainly, we don't want anybody to get any form of COVID, but at least if they get COVID, we would prefer it to be a mild disease rather than a severe disease. So it's still not too bad for prevention of severe disease. And then finally, Covaxin, there's not a lot of data. There's only data for the wild type and for Delta variant. And for wild type, it was about 80% effective. And for the Delta variant, it was about 60 to 70%. Again, higher for severe disease, but still pretty good for any type of COVID. So bottom line from this is the vaccines have some decreased efficacy against Delta variant, but still the number one thing we can do to protect ourselves against COVID, even in India right now, or even in America right now, is to get vaccinated. Here are some commonly asked questions which I have received about the COVID vaccines. Now, I realize this is a medical audience. Many of you probably know this, but I thought it could be helpful to go over. And again, these are maybe more questions I get from a non-medical audience, but still, maybe it's helpful just to just say them, and then also you can have the slides for later. So should someone get the vaccine if they've already had COVID? The answer to that is yes. Now, in resource-limited situations like India, you may want to prioritize, obviously, vaccination for those who have never had COVID. But still, theoretically, we do get some boost even from vaccination, even if we have already had COVID. So the answer to that is yes. If a patient has any food allergies, they can still get the vaccine, no problem. If a patient has had an allergy to a previous vaccine or some other IV medication, then it's a little bit more complicated. You need to get some more details from the patient about that. And you may need to consider referral to an allergy specialist depending upon the details. People ask if the vaccines cause someone to have a positive SARS-CoV-2 PCR test. The answer to that is no. Some people ask, can the vaccines give somebody SARS-CoV-2 infection? And the answer is no, that's biologically impossible based on the way they're designed, particularly Covishield and Covaxin. Covaxin is inactivated. Covishield only has one portion of the genome of the virus, so that it's impossible to get COVID from the vaccine. And then people ask, do the vaccines alter somebody's DNA or genes in any way? And the answer to that is also no. So I'm going to shift gears now and talk briefly about isolation and quarantine strategies for COVID-19. First, the question, I often get a question, is there a difference between the terms isolation and quarantine? Or do they mean the same thing? Interestingly, it's often used, the terms are used interchangeably, but there's actually a technical difference in the definition of these two terms. Isolation refers to separating oneself from others when you're symptomatic with a condition or you're having a positive test. So you have the disease, you have the infection. Quarantine means is slightly different. It means separating yourself from others, even while you're asymptomatic during the incubation period after you've had an unprotected exposure to someone with an infectious disease. So isolation means I have COVID, I'm going to stay away from everybody else. Quarantine means somebody in my house had COVID and now I'm close to that person. So to protect other people, even though I don't necessarily have the infection, still I'm going to stay away from other people because I had a contact with somebody else. That's quarantine. So what are the typical isolation guidelines for COVID-19? For mild to moderate illness in patients who are not severely immunocompromised, the typical isolation guidelines are that they should be isolated, meaning away from other people, for 10 days since the first day that they started having symptoms. Not necessarily the day they got tested, but from the first day they started having symptoms. At least 24 hours have passed since they had any fever, and overall, clinically, they're improved. If somebody has critical or severe or critical illness and they're not severely immunocompromised, then they should be isolated for anywhere from 10 to 20 days since the first day they started having symptoms. At least 24 hours should have passed since their last fever, and overall, their clinical status should be improved. So bottom line is, when somebody has severe or critical illness, their period of isolation should be longer than somebody who has mild to moderate illness. And usually patients with mild to moderate illness are often at home, actually. They're not necessarily even in the hospital. And keep in mind the definition of severe disease, at least as defined by CDC and the National Institutes of Health here in the United States, includes an oxygen saturation less than or equal to 93%. People often ask, what's the definition of severely immunocompromised? This is a slightly unclear area right now. It's still an area of active research in the United States, meaning which type of patients tend to shed replication competent virus longer than a typical immunocompetent patient. Typically, it does not include things like advanced age, diabetes, or end-stage kidney disease. Although these things can affect your immune system, they don't necessarily put you in the category of severely immunocompromised. Typically, severely immunocompromised includes things like active chemotherapy for cancer, hematologic malignancies, recent stem cell or solid organ transplant, HIV infection, primary immunodeficiency syndrome, or receipt of immunosuppressive medications for rheumatologic or other conditions. Overall, though, the exact criteria for which type of patients tend to shed live virus longer than 20 days is not known. It's a very difficult area, actually. If somebody has acute myelogenous leukemia and they get COVID, how long is that person considered infectious? I don't think anybody knows the answer to that question. And it's very difficult and has to be handled on a case-by-case basis. It's not so straightforward. When they're immunocompetent, it's easier, but when they're immunocompromised, it's a little bit more difficult. People often ask me questions about repeat testing. Do most patients, after they've been diagnosed with COVID, do most patients need repeat testing? Overall, the answer to that question is no. Most patients do not require repeat testing after they've had COVID. So as it says there, typically repeat testing is not needed to bring somebody out of isolation if they have had COVID-19. The reason for this is PCR test positivity can persist for weeks or months after initial infection. I've seen some patients, their PCR is still positive after 4 months, but that doesn't necessarily mean they're infectious that entire period of time, nor do they pose a risk to other people. As I mentioned before, though, for patients who are immunocompromised, it's more complicated, so you cannot necessarily follow this. But for typical immunocompetent patients, which is the vast majority of patients, you usually do not need repeat testing to take somebody out of isolation. And here's a good study that shows that that is true. It was published in JAMA Internal Medicine Journal a few months ago. And without going into details, they studied over 3,500 patients who had had contact with people who had recovered from COVID but still had positive PCR testing. So they were out of the isolation period, their tests were still positive, and then they came into contact with other people. And the question was, did those other people get COVID from those people just because they had a positive PCR test after they were out of the isolation period? And the answer, in the interest of time, I'm not going to go over the details, but the answer was no, they didn't seem to get COVID. So the conclusion from this study was the following, and you can find it on the web. You can go and look it up. The study is publicly available. In this retrospective cohort study of a closed occupational health program, recovered individuals who continued to test positive for SARS-CoV-2 following discontinuation of isolation were not infectious to other people. These findings support time-based US CDC recommendations for ending isolation, meaning that you don't necessarily have to prove negative tests to take somebody out of isolation. So what are quarantine guidelines for SARS-CoV-2? Who needs to be quarantined, first of all? Again, quarantine means you don't necessarily have the infection. It means you've been in contact with somebody who has had or is having COVID right now. It doesn't mean that you have it. It means you've been in contact with somebody else. So who needs to quarantine? People who have been in close contact with somebody who has COVID-19, but not necessarily those who themselves have had the infection recently or who are fully vaccinated. The idea being that if you're fully vaccinated, you're obviously more protected than somebody who's not vaccinated. So what is the definition of a close contact? It's any one of the following. A close contact is someone who's been within 6 feet of someone who had COVID-19 during their infectious period for at least 15 minutes, or providing care to someone at home with COVID-19 during their infectious period, or sharing eating or drinking utensils with somebody who has COVID at the time that they're infectious. So what should somebody do if they fall in the category of being a close contact, meaning they themselves don't have COVID, but they're around somebody who has COVID? What should they do when they themselves need to quarantine? And I realize that sometimes this is not always possible. People maybe cannot stay at home. The homes may have a large number of people. They may need to go to work. There may be many societal factors why they cannot do this, but theoretically speaking, this is what they're supposed to be doing when quarantining. They should stay home for 14 days after their final contact with somebody with COVID during their infectious period. They should observe themselves for fevers, respiratory symptoms, or other symptoms. If possible, avoid further contact with other people. And one option for potentially reducing the length of quarantine from 14 days is to obtain a PCR test. And if that test is negative, then you can potentially stop quarantine after 7 days rather than after 14 days. Now, I will say again, this could be very difficult for somebody to do. Suppose they have a family member at home with COVID. Now, should they really stay at home for 2 weeks? That may be very difficult for them to accomplish. They may not have the support in place to be able to do that. So it may be problematic for them, to be honest. But theoretically, this is one of the steps that should be taken. Let me end with a brief update on pharmacological management of COVID, and then I'm happy to take any questions from the audience. I showed this slide last time I gave a presentation to this wonderful group, so I'm just going to show the same slide here. All the medicines on the left, still, they're currently not recommended for prevention of or treatment of COVID-19, regardless of disease severity. And the reason is because there have been trials that have been negative or show harm in some cases. And these include hydroxychloroquine, azithromycin, ivermectin, which I realize is very controversial, but still there's no definitive evidence. Convalescent plasma, vitamin D, zinc, and aspirin. All of these have not really shown to have any benefit, at least yet, in COVID. For patients with asymptomatic COVID, meaning they have COVID, but they have no symptoms. These patients should, of course, monitor themselves for the development of symptoms, but there's no indication for any prophylactic or therapeutic medication if the patient is asymptomatic. For patients with a mild to moderate COVID-19, of course, they can get symptomatic therapy with antipyretics and antitussive medications as needed, and it's okay to use paracetamol or non-steroidal anti-inflammatory drugs as well. Specific pharmacological therapy for mild to moderate COVID-19 is the following. monoclonal antibody therapy. Again, not convalescent plasma, but specifically monoclonal antibody therapy. There are three main options for monoclonal antibody therapy: bamlanivimab and etesevimab, which is made by Eli Lilly. But as I just mentioned a few weeks ago, 3 weeks ago, actually, in late June of 2021, this was stopped in the United States because of failure to effectively treat beta and gamma variants. So actually in the United States, we're no longer using bamlanivimab and etesevimab because of this. The second option is a combination drugs made by the company Regeneron. And the third was recently approved in the United States only a few weeks ago by the company, for the company GlaxoSmithKline, and the medication is called sotrovimab. So the two main options now in the United States are these bottom two, casirivimab and imdevimab, or sotrovimab. So who should get monoclonal antibody therapy? Not necessarily all patients need monoclonal antibody therapy. Really only patients who are at high risk for progression to severe COVID. So who is at high risk for progression? Patients with obesity, kidney disease, diabetes, or who are older than age 65. I'm not going to read this whole list. As I say, you will have these slides, but bottom line is only patients who are at high risk for COVID-19 should really get monoclonal antibody therapy, especially the number of medication is limited. So it's best to use it for patients who are at high risk of progression. Turning now to management of severe and critical COVID-19, these patients are typically hospitalized. The most important medication is dexamethasone. Still, since July of 2020, 1 year ago, the recovery trial results became available. And since then, dexamethasone is still the most important medication for patients with severe and critical COVID. Remdesivir can be considered. It may decrease time of hospitalization, but does not necessarily improve mortality. And then finally, the other sort of new drug to consider is an anti-interleukin-6 inhibitor called tocilizumab. So when to use tocilizumab? I showed this slide last time, but I'll show it again here. Patients with severe or critical COVID-19, the patient is getting worse. There's evidence of systemic inflammation as evidenced by a C-reactive protein or CRP greater than 7.5 milligrams per deciliter. In some places, this is listed as 75 because it's 75 milligrams per liter. So anyway, the units matter, but it's either 75 or 7.5 depending upon the units. Within 24 hours of being admitted to the ICU, and for mild to moderate disease, it's not really needed because it's probably the patient is not sick enough that it's going to be a benefit. And then much, much, much later in the course, when the patient is very ill, has been in the ICU for 2 weeks, at that point, it's probably too late to do anything. It's not going to be effective or efficacious. So the time to give tocilizumab is when the patient is inflamed, sick, and getting worse, and just got into the ICU. That's a good time to potentially think about tocilizumab. This is the newest information that was just released about 1 month ago. And even in our hospital, we have not yet started doing it. And it's a change from last time when I gave a presentation to this group. Last time I was here, I said monoclonal antibodies don't need to be given for patients who are in the hospital. However, since then, new data has come out from the recovery trial. And the recovery trial in the UK showed that Regeneron's monoclonal antibody therapy was in fact effective for patients who were hospitalized with COVID if they were seronegative for SARS-CoV-2, meaning at the time of admission, somebody checked their antibodies. And if at admission, their antibodies were negative, then monoclonal antibody therapy for hospitalized patients, in fact, was effective. So there's a distinction between those who are seropositive and seronegative. But even in my hospital right now, we're not consistently doing this. But it is something to consider. If somebody is hospitalized for COVID, at the moment of admission, if you check their antibodies and it's negative, there could be some mortality benefit from giving such a patient monoclonal antibody therapy. This is very new, only within the past 1 month. Finally, Dr. Kairam asked me, he said somebody asked a following question, I thought I would answer it here. He said, what lessons could be learned from the recent crisis in India with a sort of very high number of COVID-19 cases? What can we think about and what lessons can we learn from that experience? And this was what I thought we could learn from that experience. Some of it is out of our hands. Some of it is the natural evolution of the virus. Once it starts with exponential growth, it's very difficult to bring it back under control, actually. And so some of it is out of our hands, and we have to have some humility about that. Some of it is we cannot control all of it. But to the extent we can control things, here were the things that I thought are most important to take away from the recent crisis in India. First, in my view, the most important thing is to emphasize fundamental concepts. To me, that's more important than thinking about a lot of very esoteric or theoretical or experimental ideas or approaches. To me, we tend to know what works, and the most important thing is to emphasize those fundamental approaches, including the following: isolation and quarantine as appropriate, avoiding very large gatherings, which I realize is difficult, especially, I mean, in the United States, it's difficult. In a country with more than 1 billion people, that can be difficult. Vaccinate as quickly as possible, which I know India is doing now a great job, really trying to increase the vaccinations as quickly as possible. And remembering that transmission predominantly occurs in crowded indoor settings. There's not too much outdoor transmission, although it can happen when there's a huge group, but predominantly it happens with large groups indoors. Universal mask policy, especially indoors, can be very helpful. And then finally, in terms of treatment, I'll say the same thing that I've usually been saying at these presentations, is that sticking to evidence-based therapies is probably the best approach. Otherwise, it's impossible to know what's working and what's not working. And there can also be harm associated with excessive treatments. So I think that's also an important concept. People often ask me, but what if something works and we're not using it because we don't have evidence yet? That's true. It may be the case that you may be missing giving a patient something, even if it could theoretically work, if we don't have evidence. On the other hand, because we don't have evidence, it could actually be harming the patient. So we don't necessarily know. And there are so many things out there we could be giving somebody, but sticking to what we know actually works is probably the safest approach. Otherwise, we're just guessing. And many things we think they're going to work, and it turns out they don't necessarily work. I think the sort of the sort of safest approach is to give people what we know works, along with following other strategies. That's probably the best way to try to control when you have an outbreak or a pandemic or something like that. This is kind of a philosophical approach. Thank you all for your attention. As I said, I will be sharing these slides. My contact information is there. I will be happy to answer any emails. A few people have emailed me from the prior presentations. I'm always happy to answer. And then let me stop sharing my screen. And as I said, I will share all these slides with Dr. Gundapalli, Dr. Kairam, and Dr. Sudhakar.
Thank you, Pradeep. That was an excellent presentation. I see one question in the chat box, but I wanted to ask you a couple of questions. Whenever you approve a vaccine or talk about vaccine efficacy, is it true that 60% is pretty good? And here we're talking about Pfizer being 94% or 98%. The higher, the better. But what would you consider a vaccine to be reasonably good?
Yes, thanks, Dr. Gundapalli. When the US Food and Drug Administration, FDA, first set out guidelines for how efficacious the vaccines should be before they were going to receive authorization, they set a threshold of 50%. So 95% was very, very good. Every year, even for flu vaccination, some years is good, some years is less. A sort of not good year is about 30%. A good year for influenza vaccination is probably 70, 75%. So 95% for Pfizer and Moderna was considered an excellent outcome. Now, the other point I want to make is that, we quote Covishield, for example, let's say is maybe 70% efficacious. But keep in mind, that's all symptomatic COVID. So that includes, for example, mild, moderate, severe, critical disease. So it's lumping all of those together. It's any form of symptomatic COVID. But if you take just the fraction, that is patients who are severe, critical, hospitalized, dying, the number actually goes way up. So for example, for the Johnson & Johnson vaccine in the United States, the number for any type of COVID was 70%. But then if you looked at severe and critical COVID, it was 85%. If you looked at hospitalizations, it was almost 95, almost 100%. So the number goes up as you talk about increased severity of disease. So that's another concept I wanted to bring out.
Yeah, because when some people are dishing out the vaccine, saying that it's only 60%, we want 94% vaccine. I mean, it's still pretty good compared to the previous vaccines for other diseases. That's all I wanted you to point out. Just one more, and then I'll ask the audience questions. You mentioned about, giving vaccine to those who have had COVID, but you didn't talk about the timing.
Yes, thank you, Dr. Gundapalli. Yes, in the interest of time, I already went over a little bit on time, but in terms of timing, in general, what is recommended by CDC is the following. Once somebody is out of the isolation period for COVID, they can actually get the vaccine pretty much any time after that. Some people say they can wait for 3 months if they want to. They can do that. I would say in India, because the population is so big and there's relatively limited number of vaccines, it may be better to, if somebody has COVID, to maybe wait 3-4 months because they're probably protected, and better to maybe use that vaccine on somebody who has not had COVID. So in the situation that's going on in India, it may be preferential to give those vaccines to other people, but not because it's a problem for that person to take the vaccine. They can usually take it immediately, even after they have gotten COVID and they're out of the isolation period. There's one exception to that. The one exception to that is if somebody has received monoclonal antibody therapy or convalescent plasma, then they are recommended to wait 3 to 4 months after getting that therapy to receive the vaccine. Otherwise, it doesn't matter. But again, I just want to emphasize in a situation like India, where there are so many people and so many vulnerable people and more limited number of vaccines, may be better to use those vaccines on people who have not yet had COVID.
I'm going to take some questions from the chat box and then also take some from people who are raising their hands. There are quite a few questions about the booster dose or a third dose for any vaccine, and also about what is approved for pediatric. What are the different vaccines?
Sure. So regarding booster dose, there's been a lot of discussion about this. Currently, in the United States at least, no booster dose is recommended currently. And the reason for that is, number one, there's not really any clinical trials to suggest that people need a booster dose, number one. Number two, the vast majority, I mean, the overwhelming majority of people who are dying right now from COVID are usually unvaccinated people. Now, there have been a handful of people who have been vaccinated who have still gotten COVID and in fact have died, but that number is very, very small. More than 90% of people dying more than 95% of people dying are unvaccinated. So actually just last week, United States CDC and FDA, Food and Drug Administration, suggested no additional vaccines are required. Now, I have to say, booster doses. Now, I have to say that was in the United States where we were predominantly using Pfizer and Moderna. I realize in India, the situation is different, where predominantly people are using Covishield and Covaxin. But still, to my knowledge, there has not been any new big study suggesting that booster dose is really very much needed, meaning that there's so much breakthrough infection and so many people dying even after vaccination. It is true that that does happen, but it's more rare. And given that the population is already more than 1 billion, I think trying to get everybody at least the initial couple of doses is probably the better strategy on the population level before we start thinking about boosters. Now, with regard to pediatrics, I will say that we have one vaccine here in the United States, which is approved for people above the age of 12, and that's Pfizer. Now, I will say the risk of a bad outcome for healthy people less than age 18 is pretty low. Usually, if somebody is less than age 18 years old and they're healthy, they're not obese, they don't have any major medical problems, their odds of a bad outcome is very low, actually. the risk of COVID really goes up with age. As I know everybody knows, the age gradient is very steep, along with people who have comorbidities such as obesity, cardiovascular disease, etc. So the point I'm making is, in a situation where you have 1 billion people population and a more limited supply of vaccines, in my view, prioritizing older people or people with medical conditions is probably a sort of better strategic approach on a population level rather than children.
I'll just read a comment in the chat box. It says, is there a demographic observation in new cases in some states in USA, or just poor vaccination rates explains the surge in states such as Missouri? In India, there seems to be a slight uptick and concern about children below 18 in the next possible surge if in the numbers if it happens.
Yes. In the United States, the vast majority of people right now being hospitalized or dying from COVID are unvaccinated. Now, amongst kids, obviously less than age 18 or less than age 12, especially less than age 12, they're not eligible for any vaccines. Now, there have been some very small number of kids who have died from COVID-19, but the vast majority of those kids who have died from COVID-19 usually have some medical risk factor. The most common risk factor that kids have that allows them to have a bad outcome from COVID is obesity. That's probably the #1 risk factor. After that is sometimes cardiovascular disease or other types of medical conditions. So a typical healthy kid, if the question is, can a typical healthy kid die from COVID? The answer to that is, yes, it can happen, but the odds of that are very, very, very low if they're healthy. But if they have obesity or cardiovascular disease or some other condition, then the risk is going up. So in the United States, the surge we're seeing is predominantly amongst unvaccinated people, and the few cases of kids having a bad outcome, the majority of those kids have some risk factors.
I have to agree with you. I was just on in the ICU last week. All the admissions were unvaccinated people with COVID. Are the isolation quarantine guidelines different with increased prevalence of the Delta variant?
No, great question. There's no reason to think that because Delta variant is more transmissible, therefore the duration of shedding is going to be any different. I think one of the main reasons for the increased transmissibility of Delta is predominantly due to the ability of spike protein to attach to the ACE2 receptor in the respiratory epithelium. But I don't think that should change the dynamics of isolation or quarantine. I think if those are followed fairly strictly, should be okay.
I will now go to the audience. The people who want to ask the questions. Let me go to Dr. Prem Kumar first. Dr. Prem Kumar, did you have a question?
Yeah. Good evening, Dr. Gunchpalli, and I must congratulate Pratik. Have a great presentation. And I have a couple of questions. And as you said, earlier we used to give monoclonal antibodies to people who are not hospitalized. But now the recent recovery trial, as you said, can be given to hospitalized people if they don't have antibodies. So can we include it in our protocol that all the hospitalized patients, we check for antibodies, and if the antibodies are not there, can we go for this monoclonal antibody treatment? That's #1.
Yes, thank you, Dr. Prem Kumar. I would agree with you. I mean, the recovery trial, I should say that publication right now is not peer reviewed. It's on a preprint server, but I looked at it and I looked at the data, and I thought it was very encouraging. So I would say if somebody is newly hospitalized with COVID, I think it's very reasonable to check their antibodies, and if they're negative, then to give them specifically the Regeneron product, because what was studied in the recovery trial was the combination of casirivimab and imdevimab, that one specifically, not bamlanivimab and etesevimab. So I would give the Regeneron product if they're seronegative, and they get hospitalized, I think that is reasonable. I would say, though, that it hasn't been peer reviewed yet. Maybe that's still maybe okay. It may take some time. And it hasn't officially been recommended yet by NIH or the Infectious Disease Society of America. But that said, I thought the data was pretty encouraging. So maybe it's going to come in the guidelines soon. I'm not 100% sure, but I think that's a reasonable approach.
Yeah, thank you, Pratit. And another question regarding, tocilizumab usage. In India, the IL-6, the ordering of the diagnostic test IL-6 is left and right. Even a patient who is asymptomatic and even at home, when they visit the primary care physician, they advise a COVID panel in which all the CRP, D-dimer, ferritin, IL-6, everything will be ordered. And in the hospital also, it's used, very, very rampantly and indiscriminately. And based on IL-6 levels, they go for all these things. But nowhere in the studies there is a basis for IL-6. Either it is a remap cap trial or a recovery trial. The IL-6, 75, or another study it gave 150. So I would like to, emphasize on that point, and the audience also, that relying on IL-6 levels, and after giving the anti-IL-6 receptor blockers like tocilizumab, monitoring with IL-6 is not that useful, or rather it is not recommended.
Yes, Dr. Prem Kumar, I would agree with you that the use of tocilizumab should be two things in my mind. It should be the combination of the patient's clinical status and some evidence of systemic inflammation, usually judged by CRP levels. But if somebody's asymptomatic at home, I don't see much. I agree with you. I don't see much utility in checking all those things. Now, if they come into the hospital and they're getting worse, then I usually check all those things. And if they're getting worse, especially they're about to go to the ICU, and those CRP levels, ferritin level, everything is very high, then I think that's a good patient to get tocilizumab. I agree with you. But if somebody's at home, I don't see much value either.
Yeah, because every patient who visits my office, they walk into the office just like that, and they show me the reports ordered somewhere else, a COVID panel in the lab. My IL-6 is so high, please give me tocilizumab. That's how they ask, and the IL-6 is very indiscriminately used in these parts. And my last question to you is that sotrovimab available in US? If so, what is the dose, and is it a one-day administration or the two? And will sotrovimab beat all the variants?
Yeah, great question, Dr. Prem Kumar. I believe it's one-time infusion. I would have to check. Regarding the exact dosage, again, I would check the emergency use authorization. It's publicly available, but it's also a one-time infusion. It is available in the United States. I don't think it's widely being used. The most common that we're using right now is the Regeneron product, casirivimab plus imdevimab. But I think some people may be using sotrovimab. But I think it's still new for people. They're still hearing about it. They're still learning about it. So they don't feel so comfortable yet. To our knowledge, it covers against all the variants. But I would say that is a gray zone right now, meaning maybe in a few weeks, few months, we may find it's not covering all the variants. But for right now, I haven't heard anything that it's not covering the variants.
Thank you so much, Pratik. And thank you, Dr. Kunt, for giving me this opportunity. Thank you.
I'll get some questions from the chat box. Dr. Sarkar asked you, what is the earliest time a patient can develop reinfection after the last episode of infection?
Okay.
And how to diagnose it, as RT-PCR may remain positive due to a previous infection?
Yes, excellent question. Okay, it's a little bit complicated, but let me just make a few points about reinfection. Okay, first, reinfection with COVID is possible. It can happen. It's thought to be quite rare, meaning immunity after natural infection is thought to be pretty good and lasts for at least 6 months, probably more than that. However, reinfection can occur. Some cases, reinfection is milder than the initial infection. In some cases, rare cases, it can actually be worse than the first infection. Usually it's milder though. So I just want to mention that. Overall, it's pretty rare. Generally speaking, it does not occur within the first 3 months. So if somebody is within 3 months of their prior COVID infection, it's highly unlikely they would have gotten a reinfection. Not impossible, but highly unlikely. Now, you're absolutely right. The diagnosis becomes difficult because PCR could stay positive for a long period of time. So in that case, you have to go by the combination of laboratory testing plus clinical assessment. For example, suppose back in February, somebody had COVID. Then they went 4 months, they felt perfect, they felt fine, totally asymptomatic. Then 2 months later, 6 months later, again, they develop fever, cough, shortness of breath, some typical symptoms of COVID, and their test is positive, and everything else is negative. You could say, well, is that definitely COVID? Because maybe the PCR is just positive from the first time. But in that kind of case, you have to put together the clinical situation. The patient was asymptomatic for 4 or 5 months, and then now their test is still positive. So both of those things being true seems unlikely to be a coincidence. So it's probably the case that they have COVID. On the other hand, if somebody develops suddenly new symptoms within, let's say, 3 weeks or 1 month after their prior infection, it's much less likely that that's COVID. So the sort of overall summary answer to the question is, it is a little bit difficult, these circumstances, because the PCR can still be positive. However, you have to put together the combination of the laboratory testing and PCR testing. The final point is, there are more sophisticated ways to truly prove reinfection, which is genetic sequencing. However, and that's officially, actually, if you want to truly diagnose reinfection, you have to prove that it's a different genetic sequence. However, practically speaking, for most of us seeing patients in the clinic or hospital, that's not possible. It's not feasible. So you have to just use clinical judgment plus the results of the testing. But officially, it could be checked with genetic sequencing.
Another question is, could you comment on Guillain-Barré with adenoviral vector vaccine?
Yeah. So in the United States, about 1 week ago, there was an announcement, maybe 5 days ago, actually, there was an announcement that the Johnson & Johnson vaccine, which is adenovirus 26, adenovirus vectored vaccine for SARS-CoV-2, was possibly associated with about 100 cases of Guillain-Barré syndrome in the United States. Now, a few points to make about that. First, about 12 million doses of Johnson & Johnson vaccine have been given in the United States so far. Only about 100 cases of Guillain-Barré have been reported potentially associated with that vaccine. Now, there is some baseline rate of people getting Guillain-Barré in the population. So, I mean, if people could just get Guillain-Barré, I mean, that happens. However, it was slightly higher, the number of people you would expect who got it even after vaccination. Now, I will say 100 is not a huge number. However, we don't yet know more details about what types of patients those were. For example, were they all young patients? Were they men, women? Were they had some risk factors, anything? We don't know any of that. There has not been any publication about that yet. It was just announced by press release. And the US FDA put a warning on Johnson & Johnson vaccine that this is a potentially very, very rare outcome that could occur after receiving Johnson & Johnson vaccine. And then I will say, I have not seen it been reported yet with AstraZeneca or Covishield vaccines. Maybe that'll come in the future. I haven't seen that yet. I've only seen it for Johnson & Johnson vaccine in the United States. And then some people have asked, you know, can it happen with other vaccines and stuff? Is it plausible? The answer is yes. The most famous example of Guillain-Barré after a vaccination was in 1976, swine flu vaccine. There was an increased number of people who got Guillain-Barré after swine flu vaccination in 1970s. Even now, the influenza vaccine has possibly slightly higher risk of Guillain-Barré. Even now, it's probably not that high risk. It's very rare. but there is possibly some association there. And then the only other vaccine that I'm aware of that has some possible association is the Shingrix vaccine. Shingrix vaccine is a recombinant zoster vaccine, which has some very small increased risk of Guillain-Barré with the vaccination. So overall, I would say there have been only 100 cases reported. It's still thought to be pretty rare, but we need more details. What kinds of patients, demographics, risk factors, et cetera. We don't know that information yet.
There was a question asked earlier. If somebody had Guillain-Barré in the past, maybe 5-10 years ago, can they take the vaccine?
Excellent question. We don't actually have evidence for the answer to that, but what I would advise somebody, let's say my family member in India asked me, I had Guillain-Barré 5 years ago, should I get an adenovirus vaccine? I don't have any data for this statement, so I want to admit that up front. However, given that Covishield is an adenovirus vaccine, I would probably advise them to go for Covaxin rather than Covishield if they really had Guillain-Barré. Now, I have to say that has not yet really been reported with Covishield, but since it's a similar technology to Johnson & Johnson vaccine, I would err on the side of caution and just give them Covaxin. Now, if they truly had no other option, meaning that for some reason they cannot get any other vaccine, maybe they take a risk and just take it. But if they have an option, maybe they can go for something else. Again, I want to be honest, that's not a purely evidence-based statement, but I'm just going on my best logical thinking.
Another question is the age criterion based on logistic issues or safety issues? Is it safe to give vaccine for children less than 12 years or not?
Yeah, I would say the studies have not been done yet. It's pending. Is the answer. So we don't have evidence that the vaccines are entirely safe and efficacious on a very large population level. So I would say it's absence of data right now. And those trials are going on. And it's expected that probably in 6 months to 9 months in the United States, we should get authorization for children younger than the age of 12. I will just point out one area of controversy, which I won't go into details for the interest of time, but with the mRNA vaccines in particular, Pfizer and Moderna, which I realize are not the predominant, what is being used in India, but just to mention, there are some concerns about episodes of myocarditis and pericarditis, especially in younger men, meaning men less than age 25, around 15 to 25 years old. There was a large number of cases in Israel of patients who had gotten Pfizer vaccine in that age group, especially amongst men. And so because of that, although it's not the case in America, some European countries, United Kingdom, Germany, and a few others, have taken the approach for children younger than age 18. They are not, in fact, actually, they are not recommending universal vaccination for kids less than age 18. They're only recommending vaccination for children with obesity or other medical comorbidities, cardiovascular disease, some other kind of condition, that those children should get vaccinated because the risk of a bad outcome from COVID is higher. So I just want to point out that even in the United States and Europe, there's slightly different recommendations for children, predominantly because of this signal of myocarditis and pericarditis in young adolescent men in particular.
I will now take a question from the people who have their hands up. Dr. Faninder, are you still interested in asking your question? Okay. There's another question that says, can the PF4 antibodies be falsely negative in vaccine-induced thrombosis?
Yeah, very good question. That is an area that we are still learning a little bit more about. So there are a couple of different names for that I just want to mention. One is called VIT, vaccine-induced thrombosis with thrombocytopenia. The other name which is the name that's used in the United States, is TTS, thrombosis with thrombocytopenia syndrome. Both of these are due to rarely they are due to either Johnson & Johnson vaccine or AstraZeneca vaccine, both of which are adenovirus vectored vaccines. The mechanism of TTS or VIT, vaccine-induced thrombosis with thrombocytopenia, is thought to be similar to HIT, heparin-induced thrombocytopenia, heparin-induced thrombosis and thrombocytopenia. And the reason is thought to be activation of PF4 antibodies and causing thrombosis and thrombocytopenia. Because HIT, for example, is one of the few places in hematology where you're having a clot, but the platelets are very low. So it's a little bit unusual. So it's also unusual that this is happening in the setting of a vaccine. So bottom line is the mechanism is still being worked out. The proposed mechanism is similar to HIT, as you said, activation of PF4 antibodies. However, in my mind, the laboratory testing of PF4 antibodies is supportive, but as yet not definitive. In my mind, it's more clinical diagnosis, meaning somebody got a vaccine and then within 2 to 3 weeks, they develop a very serious thrombosis, either in the brain or splanchnic or something. And then also they have very low platelets. And it's within a time frame of having received an adenoviral vaccine. If you check a PF4 antibodies in that patient and they, whether they're positive or negative, maybe it helps the diagnosis a little bit, but on the other hand, in my mind, it's mostly clinical in timing in relation to the vaccine and the clinical situation, a serious thrombosis and thrombocytopenia after the vaccine. So in my mind, that's the most relevant way to make the diagnosis.
Dr. Paninder, are you unmuted still or not? I still see that you're muted. I don't know if I can unmute you. I'm trying. Or you can post your question on the chat box. You're still muted.
I'm not able to unmute. Yes, madam. I'm able to unmute me. Unmute myself. Yeah. Madam, good evening, madam. Sir, good evening, Dr. Kulkarni. So I have a small practical question regarding the increased transmissibility. We know that the variants are having increased transmissibility, and is the mortality related to that, and means more number of cases in the hospitals are overfilled, and then that is due to increased severity. So is there any particular classification that the variant is very severe and less severe or moderate severe, and then is a typical progressor or rapid progressor? What is your observation, sir?
Yes, thanks, Dr. Fernandez. I think most of the increase in hospitalization and then subsequent serious disease, death, etc., is mostly due to increased transmissibility, especially amongst unvaccinated. I think that's a predominant. However, I will say, for example, if you look at alpha variant probably has some increased disease severity. In addition to, meaning you take the same 2 patients, give them the wild type and alpha, maybe the alpha will be a little bit more likely to have a severe disease. People, the question I'm getting right now is that the same for Delta? And I think the truth is we don't exactly know yet, but still by and large, I think most of the situation we're seeing in the United States right now is predominantly due to transmissibility. Maybe later on we'll find out there's also some increased severity as well. But in my mind right now, the main issues are transmissibility and lack of vaccination.
Yes. So because when we talk about any variant, new variant, we say that into the public, right? Increased transmissibility, increased severity. So we won't have a distinction as a primary care physician will be having good guide. So another question is there any distinct clinical presentation pertaining to or pointed to a variant such that the primary clinician can immediately refer to a specialty?
Right.
Yeah.
I have not heard about any specific different clinical presentation of, let's say, wild type COVID compared to alpha, beta, gamma. I haven't heard anything about significantly different clinical presentation. Now, maybe it'll turn out there are some subtle differences, but from a practical standpoint, I have not yet personally observed any difference or read any literature suggesting any difference.
Thank you very much, sir. Thank you.
I will take some questions from the chat box. Any new vaccine to cover newer variants, as in case of influenza? Or another question that can be clubbed with that is, are they planning on combining flu and COVID vaccine?
Yeah.
Or do we need to take it every year?
Okay, so regarding the question of combination flu and COVID, I haven't heard about specific plans to like literally combine it into one injection. I mean, maybe that'll happen down the line, but I haven't heard about that. The other thing is, I would say most flu vaccines are made by, you know, egg-based production. So the production format is different. Whereas, you know, at least in the United States, we're using Pfizer and Moderna, which are mRNA technology. So the entire technology is different. Even Covishield, AstraZeneca is using adenovirus vectored vaccine. So the entire technology may be different. Maybe they're going to combine them, but I haven't heard anything about that. As far as, are we going to need to take a COVID vaccine every year? That's the most important question right now. And I don't think we know the answer to that yet, is the sort of honest truth. In the last 2 weeks in the United States, Pfizer, the company, has put in for an application to request a third dose booster for people who got Pfizer. However, they have not yet provided clinical outcome data, meaning their data showed if I give somebody a third shot, their antibody levels go up. But the level of antibodies in the circulation may not be the only thing that correlates to protection, because we have memory B cells, we have memory T cells, we have other facets of the immune system. So all of this to say, CDC and FDA last week said at this moment, July 2021, right now, we don't yet need a booster shot. And for example, you know, myself, maybe for Dr. Guntupalli as well, you know, I took my first shot in December. So even for me, it's been maybe 7 months since I got a vaccination. But, you know, I'm not planning to, at least yet, get another booster or anything like that at this moment. Whether we're going to need it every year, I think is an open question. I think it depends upon duration of immunity, which is still an unknown question. It also depends on what new variants may come out and the extent to which they escape our current immunity. My hunch is we'll probably need some booster in the future, but I don't know yet exactly when that will be.
Yeah, I think the trials, even at Baylor, they're having some trials on booster. And I had mine in September because I was part of the trial. They keep drawing my blood every so many months. I suspect they're trying to gather data, how long it lasts, the antibodies, and maybe make a determination. There is a question that says patient aged 33 died within 24 hours after receiving vaccine, had pontine bleed, and clot at the injection point.
I don't know. That would be a little bit unusual. I haven't heard of somebody dying within 24 hours of vaccination. Usually thrombosis with thrombocytopenia syndrome or vaccine-induced thrombosis usually occurs within, you know, 3, 4, 5 days up to 2 weeks after the vaccine. I mean, that's a little bit unusual. Yeah, I don't know. Without knowing the details of the case, that's a little bit unusual to be from vaccine, but yeah, I'm not sure.
Sometimes it may be true, unrelated. We don't know. I don't know. One question from Dr. Prem Kumar: when do you use baricitinib?
Yeah, I didn't get into it in the interest of time, but just to you know, go to baricitinib. Bottom line is the following. They tried to do a study of remdesivir plus, this was actually in the United States, it was called Act 4 trial, remdesivir plus dexamethasone versus remdesivir plus baricitinib. That was the trial. And they stopped the trial early because of futility, meaning there was no benefit to remdesivir plus baricitinib versus remdesivir plus dexamethasone. They were equal. So since dexamethasone is much cheaper, everybody said, okay, just go for remdesivir plus dexamethasone. As I said, they tried that trial, but they stopped it early because of futility. So bottom line is, really the only place in my mind to use baricitinib is if for some reason, and this is pretty rare, but if for some reason the patient cannot take dexamethasone, maybe, I don't know why, maybe severe DKA, diabetic ketoacidosis, or maybe some other reason why the patient cannot get dexamethasone, then I give the patient remdesivir plus baricitinib. But if the patient can take dexamethasone, then I'd simply give remdesivir plus dexamethasone. And there's a trial that shows that that's just as good as remdesivir plus baricitinib. So basically, I only use baricitinib if I cannot give dexamethasone for some reason.
Okay, I see Dr. Naveen's hand. He raised his hand. Dr. Naveen, do you want to ask your question?
Yes. Hello, everyone. Wonderful talk to Dr. Kulkarni as above. Thank you, Dr. Gundapalli and the principal sir for bringing Kulkarni back again. I just want to inform this group about that WHO, CDC, and FDA position released last week about this third or booster dose. However, Dr. Kulkarni cleared that position, sir. Dr. Soumya Swaminathan of WHO very categorically denied any sort of third dose, either of the same make or of a different make of the mix and match strategy. That even went to the extent of saying one company which is doing it at I think in Israel could be at risk. It even commented like that. This third or booster dose of same or different make could be at risk. That's what Soumya Swaminathan said. The same thing CDC and FDA has also said, sir. Regarding this child vaccine, there was a question, sir. Only as latest as yesterday, completely indigenous Indian make Zydus Cadila group vaccine, Zydovac D. First time in the world DNA technology, sir. That is, they finished their clinical trials and they gave their midterm results to our DCJ of India and is likely to get approved, sir. It is a 3-dose vaccine, sir. It is a 3-dose vaccine, Zydus Cadila, Zydovac D, sir. It is most likely to get approval anytime next week, sir. And Covaxin trials are all, this is for 12 to 18 age groups, Zydovac D, completely indigenous Indian technology, sir. And Covaxin trials are also on from the 2 to 2 years age group. Trials are also on, sir. Covaxin, Bharat Biotech trials are also on, sir. Thank you, madam, for the opportunity.
Okay,
Thank you, madam.
Another question. It says, I had question about people getting Moderna or Pfizer in the USA, then going to India and asking if they can take AstraZeneca for second dose. Any data on mixing different vaccines?
Right. The mix and match studies are ongoing. Even actually, as you said, Dr. Gundapalli, at Baylor, we are doing those mix and match vaccines. I have not yet seen a big trial of mix and match vaccine. I saw a small study published in Lancet. I think I saw maybe 3 weeks ago. I can't remember, but small trial of, I think it was 2 doses AstraZeneca versus 1 dose AstraZeneca followed by mRNA vaccine. I think that was the trial, but it was phase 2, relatively small trial. I have not yet seen a large scale mix and match vaccine trial. So a lot of times I get the question, if I got first dose, let's say Covishield or AstraZeneca or something like that, then can I get a second dose mRNA? People ask that question. And then sort of my answer is there's no large trial that shows that that's efficacious. Now, you can sort of theoretically think that it should be okay, but sort of officially speaking, such an approach is not yet recommended. But I would say that those trials are coming. So maybe we can wait and see what they're going to show mix and match trials. I think we need larger trials because the trials we do have right now, they had 30,000, 40,000 people, huge, big phase 3 trials. So we would need some equivalent level of proof of efficacy, I think, before we go for that strategy broadly.
Okay, I think we have pretty much exhausted all the questions, and it's, maybe I can look at some of those. It says, how about taking other vaccines, post-COVID vaccine, example, tetanus toxoid?
I mean, I think it should be fine. There shouldn't really be any issue with getting other vaccines after having recovered from COVID. So, for example, if you want to take a tetanus after recovering from COVID, I haven't seen any reason why that should not be okay.
I mean, it's 9:30. We can stop here. I can just ask you about ivermectin. I know there was a recent Egyptian trial that was kind of withdrawn from preprint because of ethical issues. But I see that in the India Department of Health, they still, at least the last time I looked at it, it was still on their website. Anything?
Yes, I mean, Dr. Gundapalli, I didn't go into it in detail, but ivermectin has become very, I don't know how to say, controversial. It's also become, in the United States, very weirdly political as well. I don't know why, but anyway, it has become that way. Bottom line is, as you said, there was the study from Egypt, which was a pretty big study, but then, as you say, some of the data were fabricated or there were some ethical issues with that trial. Subsequent to that, a large meta-analysis was actually published just last week in a fairly prominent journal in infectious disease called Open Forum Infectious Diseases. And they published a meta-analysis of ivermectin showing benefit. However, they used that trial. It was the biggest contributor to that meta-analysis. So bottom line is ivermectin, I think we don't have one good sort of very large, well-designed, randomized control trial that I'm aware of showing some sort of very definitive benefit that has been well-designed, well-conducted, no issues, no anything. If we had such a trial, I would be the first to use it. But I think at least yet, right now, we still don't have that. Again, I didn't want to go too much into details on that, but bottom line is it's still not really endorsed much here in the United States because of the sort of lack of strong data that it is really doing something beneficial.
Okay, Dr. Naveen thinks maybe they took it down, but I don't know. I'm sure it's a publicly available site. You can see what their recommendations are. Dr. Sudhakar, do you want me to? Yeah.
Thank you very much. Yeah, ma'am, thank you very much, Dr. Kalpalata Guntupalli, for so ably conducting and making this show very lively one, and with a lot of information and discussion. And thank you very much, Dr. Kulkarni, for such an elaborate presentation as well as answering those questions. And like every time, you have been so lively and nice to listen to you time and again. And perhaps I will be requesting you again after a few weeks. And I particularly thank Dr. Ram Kairam for taking keen interest on this to get Dr. Kulkarni at this juncture. And with those words, I thank everyone who have participated in this particular session. And thank you all. And let's meet again next week at the same time. Thank you all. Thank you one and all. We'll end the meeting here.
One question that is being asked again is pregnancy and COVID vaccine, can they take it?
Yes. I can't know. I don't know if that's saying tetanus toxoid or something else, but anyway, yes, they can take COVID vaccine. We haven't seen any much issue in the United States. And if the question is, can they take tetanus, a shot as well? That Tdap should be fine. As tetanus, diphtheria, pertussis should be fine as well. We routinely give it in the United States to pregnant women.
All trimesters, any trimester, can they take?
Theoretically, yes. I know some feel a little bit uncomfortable in first trimester. So, I sort of understand that. That's the period of fetal development. If somebody wanted to wait until the third trimester, that's probably it's okay. The recommendation is it can be taken anytime, but if there's any discomfort later, is probably okay, because fetal development is done by that time. So anyway, thank you, Dr. Sudhakar. Thank you, Dr. Guntupalli. Thank you, Dr. Kairam. I really appreciate it. And thank you all very much again.
Thank you. Bye.
Bye. Have a good day.
Yeah.